Hey everyone, thanks so much for coming. So this paper is about an innovative healthcare model, group medical visits, as a form of care that reconfigures standard hegemonic patient-provider power relations by making peer relationships amongst patients and individual narratives central to the process of healthcare. Traditionally, medical visits have been a one-on-one interaction between a patient and a clinician. When we all go to the doctor, that's typically what we experience. But the emerging phenomenon of group medical visits allows clinicians to conduct visits with multiple patients at once using new routines and processes where patients receive care together. So I'm arguing in this paper presentation that in many group visits, though certainly not all of them, healthcare providers and patients are both acting to refute hierarchical and unequal practices that are common in standard medical care. The more participatory interactions that they're creating echo feminist health movements of the past and also in the present. There are photos in here that are not from my research, but that are of real group medical visits. So a brief overview of this presentation. I'm going to give a little bit of background on what group visits are and some differences between group and individual care. Talk a little about my research methods and a few major findings and concluding thoughts. So this picture is from one of the sites where I did research, and it's a clinic, and this is a big calendar that they have up on the wall of some of the programs that they have there each week. So some of these are things like on Mondays they give away vegetables for free and they have line dancing, but a lot of these things are actually places where people can see a doctor while participating in yoga, for example, or energy and wellness, chronic back pain. They're having a medical visit while kind of participating in support and education setting. And what group visits do is essentially bring together a group of patients and one or more healthcare providers for medical care, for education, and for peer support. So that might look like people getting their medical care all sitting in the circle, listening to each other have their medical visit, or sometimes the healthcare providers pulling people out one at a time to have a slightly more private interaction. It's been most commonly used for prenatal care and for diabetes care. Also chronic pain commonly was a major one of the sites I was looking at. And there's been a lot of research on this approach to healthcare recently, mostly focused on quantitative research focused on health outcomes that generally have found positive outcomes, particularly for diabetes, for prenatal care, that patients do at least as well, if not better. Less research on some of the other areas where people are developing these programs. One of the things I'm interested in from more the perspective of this conference is what's the potential for this approach to healthcare to kind of, so that programs have been commonly implemented in safety net kind of healthcare settings that are serving low-income people and mostly people of color. And I'm interested in the potential for this kind of program to acknowledge historical marginalization of patients and bring in people's own knowledge in an attempt not to kind of marginalize that again. A little diagram that I made to kind of drive home what's different, what's happening that's different in this kind of setting. So the squares on the left are sort of the standard healthcare situation. 4 little exam room boxes and 4 patients sitting in the exam room, spending a lot of time waiting for their one healthcare provider to come and see them one at a time. Lots of waiting. And the drawing on the right is a number of patients all sitting in a circle together in the same room with their one healthcare provider, meeting their peers instead of waiting in separate rooms, and kind of both participating in something together rather than separately. So people do this, and this is their medical care. Often it's replacing, for example, with prenatal care, it's replacing people going in for a standard appointment with a doctor or a midwife. And it means that there's space and there's time to prioritize patients' narratives as part of healthcare. And so some of the ways that that ends up looking in practice are, in a lot of the sites that I looked at, patients check their own vital signs, they check their weight, they check their blood pressure, or they help other patients do that instead of waiting for a medical staff person. And also that the healthcare providers are doing different things too. So pretty common in the sites that I observed would be at the beginning of the group to go around and do some kind of check-in, patients talking about how they've been doing or answering a question. And typically the healthcare providers would also participate in that and talk about how they were doing with their own health or their sharing part of where they were coming from. Typically, these kinds of visits might last between 1 and 3 hours, which is a really major contrast than standard healthcare in the US. People get like maybe 10, maybe 15 minutes for their entire medical interaction. And where that trend towards very short visits has been found to exacerbate healthcare inequalities and kind of reproduce them both at the level of individual interactions, like clinicians discriminating against patients of color, but also at the institutional and structural levels, really reinforcing health inequality. And a lot of the people who are promoting or advocating for group visits see them in part as a way to reduce health disparities and address injustice in healthcare systems. So this piece is one part of my dissertation research, which is a larger mixed methods project on this approach to care. I focused primarily on sites that are doing group visits, including integrative medicine approaches, so things like acupuncture, yoga, meditation. That was the focus of my work, and this segment of it is qualitative research, so I did interviews with about 25 healthcare providers and 25 patients, and spent time at 4 different organizations in California and Massachusetts, observing a lot of their different programming over the course of a few months. The main finding that I want to talk about in this presentation is the potential of group visits to change the patient-provider power dynamic, as I was mentioning. So I'm going to explore a few different aspects of this. I wanted to start with a story from one of the patients who I observed her in her group and then got to interview her as well. So this woman named Danielle is part of a chronic pain group and talked to me a lot in the interview about how she had participated in the group through a mental health crisis she was having. So she says here, I found some friends in the group and then I kind of started opening up. When I had that, I call it my break, when I was really mad at my mom, I wanted to kill her and everything. I had to apologize to the group because I was like, I don't want you guys to see this side of me. It surprised me that most of them actually understood and they had similar child trauma or abuse. They were texting me their most inner secretive things you wouldn't share with people because of my break. So we talked about this for a while and I asked her, if you had this kind of crisis again, do you think you would intentionally want to share with people now that you know people better, or would you rather keep that to yourself? And she said yes, she would definitely share again what was going on with her. And said about the other patients, they were more understanding than I thought they would have been. It helped them when I was going through it and venting it. I didn't think it was actually to help them, but it was helping me to let it go. So I think Danielle's story exemplifies some of the ways that patients in group visits participate in their own care and also participate in each other's care. Danielle is a Black woman living with chronic pain from a congenital disease and a number of other physical health issues, and also mental health issues that she described as manic depressive schizophrenic bipolar. And she's very connected with other people who participate in this group that she comes to weekly. She told me a bunch about plans that she has to sell a book of poetry that she's written and then use the proceeds to buy a laptop that folks in the group can share to do things like job applications or different kinds of projects they want to do. And so Danielle's someone who continued participating in this group through an extremely challenging time in her life. And though she says she wouldn't have intentionally shared the details of this with others in the group, like had she been in her usual state, she's really glad she did. And these unplanned disclosures resulted in a referral to mental health care that she's still participating in and finds helpful, also closer connections to her peers in the group, and the opportunity for her to feel supported and for others to feel supported. And in presenting her vulnerability this way, she didn't feel stigmatized, but now sees herself as a resource to other people with chronic pain and histories of trauma, providing a form of care to them. In this group that she's in and in other groups, people spoke to me a lot, providers spoke to me a lot about seeing patient knowledge as a form of expertise that really has a place in the medical setting. So in one group that I went to, I heard this doctor say to the group of patients with diabetes, no hay un médico en este grupo, hay 12 médicos. There's not just one doctor in this group, you're all doctors for each other, basically. And then after other staff member in his group said to me, this group visit is part of a culture change where the provider learns to share the care. And she said that to me before, and I thought, that's kind of sweet. And then I heard the doctor say this to the patients and thought, wow, he really, he means this, he believes this. And a lot of patients and providers spoke to me about this too, that patients are patient knowledge and experience is really in a central role, where typically healthcare is structured with the doctor as the expert and the patient as the layperson. Group visit providers often are seeing patient knowledge as expertise that they can leverage as a form of care to benefit other patients in the room, sometimes disrupting this kind of assumed dominance of medical knowledge. These are notes from a conversation that people in a chronic pain group had about strategies they can use on a daily basis and then in a crisis to cope with pain. One little example of ways that patients in group visits are involved in providing each other's medical care. So I observe people challenge each other and support each other in figuring out how to maintain or start new self-care practices. And at other times saw people advocate for each other in interactions with clinicians, kind of clarifying misunderstandings or trying to make sure their peers got their needs met. And a lot of healthcare providers said to me that they felt like their patients absorb new information better when it comes from their peers than when it comes from a provider. And patients also talked about this, that in many cases their interactions with each other about health were the most important part of what they were getting out of their medical care, even though they were also glad they could get prescriptions or get an exam for something that came up. So I want to close with talking a little bit about why I'm seeing group visits as potentially revolutionary care. I spent a long time facilitating these kinds of groups for people with diabetes before I was a researcher and found them really compelling, but it's been interesting to think about them through more social theory perspectives or from an academic setting, where I've really come to see them as an alternative to the kind of hierarchical and unequal practices that are common in typical care that people participate in. And in a way that many feminist health movements have tried to do in the past, making a space that puts social relationships and patients' lived experience at the center of healthcare. When I was kind of going through data and putting together this presentation, I was thinking a lot about the Black Lives Matter policy platform, where writing about reparations, large group of people, is calling for universal access to healthcare and reparations focused on healing ongoing physical and mental trauma. This call echoed the stories of a lot of the patients and healthcare providers who I spoke to in this study, who are arguing that group visits expand on access to medical care, giving people the care they need, but also practicing an ethic of ownership where while they're receiving care, patients are part of the community. So, like I was saying, I see group visits as fostering potentially liberatory social relationships that reduce the patient-provider power dynamic that most health research kind of assumes to be inevitable, as well as creating space for patients to meet each other and develop relationships. A kind of open question, two open questions that I've been thinking about as I work with this data too. I think in the current political moment, this approach has some potential to reduce the vulnerability of undocumented people and others who are being targeted by particular policies, both related to health and not directly related to health, by providing forms of peer support and community integration that can provide formal or informal forms of sanctuary. So I've been trying to think about both sanctuary and reparations and healthcare as something that lots of people don't have access to, but particularly in California, a lot of people do have access to healthcare, and trying to think about what could sanctuary and what could reparations look like in a healthcare setting, or what could healthcare providers be doing to move forward those two concepts. So I'm interested in any thoughts people might have about that when we get